I would invite our next speaker, Dr. Ijaz Hussain. He's in special interest in psychopharmacology and treatment-resistant mood disorders. Dr. Hussain has earned his medical degree at Khyber Medical College and completed his advanced training in Ireland.
Thank you, everyone. For those who don't know me, my name is Ijaz Hussain. I work as a psychiatrist here in Surrey, and I'm the graduate from Khyber Medical College, 1999. And I work with Haris. The benefit is that he definitely favors me all the time if I need any favor. But the disadvantage is that when he called me at 7 a.m. on the weekend and said that you have to do the presentation, so I have to be here. I had no choice. And he called me and said, no, you have to give me the answer now and the name of the presentation. So I thought about it, and there was a movie that I watched many years ago. It was called Prozac Nation. I said, let's just give it that name. I'm not being sponsored by the Prozac, and I don't think any of you will get the sponsorship from Prozac anymore because it is generic now. So no affiliation with Prozac. So disclaimer is that I have received the funding and grants from the pharmaceutical companies, but just so that you're aware that this presentation was mostly based on some international and Canadian guidelines. I'm happy to say that there are a lot of other psychiatrists in this room as well, and you can confirm it with them. So a few important questions. What are we going to discuss today? So the principles of management, what treatment selection, some non-pharmacological approaches, and how to deal with the poor response with the treatment. Why it is important to just talk about depression? Well, a lot of the people I think everybody almost knows about it, but just so that some facts to know about the depression. The 12 months prevalence of depression is about 6%. So every 1 in 20 people will suffer from depression. And I think if we had about 100 people in this room at the moment, I think that there's a chance that 20 of them may have a depression. I'm not saying it, but just that is what the statistics says. The lifetime prevalence is about 20%. So that means 1 in 5 people can get depression in their lifetime. If you just look around your friends, 1 in 5 will have the depression at some stage in their life. A significant number of presentations of depression. Also important to remember that depression, if you have a depression, you have a significant higher chance of having heart disease, diabetes, obesity, and you have a significant higher chance of all-cause mortality in relation to any other illness. So if you have a depression anytime in your life, there's a very high chance that you can get the higher rate of mortality as compared to the other general population. What are the principles of the management? So a few simple things to remember. Start with the structured interviews. Most of the family physicians are very good. They use the PHQ-9, G87. You can use any of them, but just have a structured interviews. Always keep in mind that 1 minute of collateral information is more important than your 1 hour of interview. Always consider that if there is an availability of that, of a family friend or a family member, whatever they tell you is more important than what you just get directly from the patient. Therapeutic alliance, very important. If you do not develop therapeutic alliance with the patient, there is almost 90% chance that your medicines or your advice is not taken. So if you haven't developed the therapeutic alliance with the patient and you prescribe them the medicines, even if it is significantly better, not going to work. Evidence-based treatment is important. The last thing which I think I want to just briefly talk about is the monitoring and providing the support to the patient. Remember that the best treatment that we have so far for the depression, like any medicines, any psychotherapy, is going to cover anything about 60% of your depression. So 40% is still left there. And if you do not provide that self-management of the depression, that 40% can never be covered. And that is what causes the significant functional problem. So the patients will be taking the medicines, patient will be going for the psychotherapies, still not well and still unable to return to work. So self-support, like how they can manage their illness. We always do that for diabetes. We always do that for hypertension. We have so many other apps now available for depression. So very, very important that no matter how well the patient is taking their medicines, it is only going to cover 60%, maximum 60%. You cannot expect more than that. So that 40% needs to be done by the patient self-help group, all those things that they need to just do themselves. What kind of treatment you should select? So it should be based on the severity of the illness. Is it mild, moderate, or severe? Patient's choice, very important that you just ask them, give them a choice. This is all the medicines. What do you think is a good idea? Available evidence, whatever is the evidence at that time, and you know that over the years the evidence may have changed. And based on the family history, my father got better with Prozac, so probably there's a good chance that the client will also get better on Prozac. So the current evidence suggests that if there is mild depression, which is typically on PHQ-9, anything below 10, it is just basically mostly just supervised exercise, web-based knowledge and support, and psychotherapy. If it is a moderate, then psychotherapy and pharmacology both can just work. If it is severe, then psychotherapy and pharmacology combined. In very severe cases, you may have to consider ECT and antipsychotic if it is the psychotic depression. Evidence-based therapies, various psychotherapies that we used, and I just briefly want to talk about the top four, which are considered to be the first line: CBT, interpersonal behavioral activation. So behavioral activation is just basically telling your client that just go out, do physical activity and social activities. They have an evidence base and they are considered to be the first line. Problem solving therapy, very interesting concept. So basically, what it means is that the patient, majority of the time, they have the solution for their problems. They come to you and they say, I don't have a job, or I am not getting on well with my wife, basically. And as a physician, our first intention is, okay, let me just tell him what to do. Okay, you should just do this, go for family counseling, go and just find the job for yourself. It looks like you're lazy. You should just get up in the morning, go and just stand up in the Labor Unlimited queue, and you will just find the job over there. The problem solving therapy basically says that the patient has a solution in their mind when they're coming to the physician's office. So rather than just basically telling them like what to do to improve their problems, just basically you have to guide them to come up with that solution themselves. And majority of the time, you just find out that the patient will just come up with the idea themselves. Mindfulness-based therapy, short-term psychodynamic therapy, acceptance and commitment therapy, and motivational interviewing has the second-line evidence for the psychotherapy range, and long-term psychodynamic therapy has a third line. Just to give you a brief idea that majority of our clients in Canada have coverage for these therapies. They're mostly going to the therapist. Just make sure that you're clear that what kind of therapy they are receiving. It needs to be one of those evidence-based therapies. Okay. So medications, I will just go, rather than just mentioning the name, I will just go through the group. So the first line, according to the new CanMed guidelines, are SSRIs, SNRIs, bupropion, mirtazapine, vertioxetine, and agomelatine. Agomelatine is not available in most of the Canada, but it is also considered to be the first line. I don't think that there are any surprises about these medicines. The second line would be mostly the tricyclic antidepressants, reversible monoamine oxidase inhibitors, moclobemide, trazodone, quetiapine, dextromethorphan, bupropion combination, which is available now in America. I think that it is not available in Canada, but I will not be surprised that you will get it very soon in Canada as well. Okay. And third line is monoamine oxidase inhibitors and reboxetine. By the time that you are thinking about the third line as a monotherapy, it will be mostly the psychiatrist that you will refer the patient to, but just so that you're aware that these are some common options as well. Okay, when you're selecting the antidepressants, what to just look at to make sure that it is the efficacy, tolerability, drug-drug interaction, and certain types of side effects. Mostly we just focus on the certain types of side effects as a physicians, but make sure that you're thinking about the tolerability. If the patient is already saying that, well, I'm not going to take these medicines, and it took you like 20 minutes to persuade him to take the medicines, there is a high chance that if you give them something which can give them quite a bit of side effects in the start, they're not going to take it after the first dose. Drug-drug interaction most important in old age population that they have like 20 other medicines that they're taking. It is quite possible that you may give them something which can increase and decrease the levels of their medicines, or can affect the or can exacerbate some of the side effects. So just be more careful with that part. Some common side effects and the medicines that can cause it. So anticholinergic, dry mouth, constipation, tricyclic, and mirtazapines are notorious for that. If you're worried about drowsiness, then mirtazapine, trazodone, tricyclic antidepressant. But just remember that in the SSRIs group, we have things like paroxetine, venlafaxine, and fluvoxamine that can also cause the drowsiness. If there are side effects that you're worried about, insomnia and agitation, then actually fluoxetine, bupropion, and sertraline can cause that side effects too, just for your information. Orthostatic hypotension, paroxetine and tricyclic antidepressants are quite well-known cause of that. QTC prolongation, citalopram, escitalopram, and tricyclic antidepressants. Just for your information that mostly we worry too much about this QTC prolongation. But just so that you're aware that actually methadone causes almost double the amount of QTC prolongation than any of these medicines. And nowadays you may notice that significant amount of our clients are on methadone. So just while worrying about it is a good idea, but just too much worry about it is definitely not a good idea. Gastrointestinal toxicity would be sertraline, SSRIs, and tricyclic overall. And then sexual dysfunction, specifically paroxetine and venlafaxine, are notorious for that. There are some long-term side effects that you need to be also aware of that I have not mentioned in here. If your clients are on SSRIs or if your clients are on antidepressant medicines, there is a higher risk of falls and fractures. So just so that you're aware, if you have clients that their overall long-term side effects, this is very prominent side effect that you have to be careful about. Special cases, if you want to just use something for your client that has complained about insomnia, then mirtazapine and agomelatine would be ideal. Just prescribe these medicines and you don't need to prescribe the sleeping pill with that. If your client is complaining that they're sleeping too much or they're tired during the daytime, then reboxetine and bupropion would be the first choice. If they're complaining about sexual dysfunction, then of course bupropion, mirtazapine, vortioxetine, and vilazodone would be some of the options that you can consider. Pharmaceutical consideration. So when to expect the response? A very common question that the patient asks me, like, when am I going to get better, doctor? I'm going to take your medicines, as you mentioned, but when am I going to get better? The important thing to remember that the antidepressant starts working within few hours. So SSRIs, like selective serotonin reuptake, that work starts within a few hours. The problem is that it has an autoreceptor in the brain as well, so that goes and stimulates the autoreceptor. And as a result, the timing, the difference that you're seeing, that the wait time that you have to wait for the medicine is all related to the autoreceptor function. There has been so many efforts made to somehow block that autoreceptor. In that case, the antidepressant will start working in days, just like any other medicines. But for the time being, the average time that we just typically wait is about 10 days. But ideally, still the old criteria was 4 weeks. I think it is totally appropriate to wait for 4 weeks to have the idea that this medicine is going to work or not. How long to continue? It is also dependent on the client's condition. Typically, we advise that 6 months after the full response, you started on January 1st, on March 1st, they're feeling really good, 6 months onward from that. Typically, that's the advice that we give. Just make sure that it is matched according to their life at that time. So somebody's saying, well, okay, December is the time for me to stop the medicine, but that is the day that I'm going to have my wedding or I'm going for my exams. Not a good idea to stop the medicines at that time. Just maybe wait for something like that. And after the proper event, you can just continue for the stopping the medicines. How to stop the medicines is another thing. If you want to stop the medicines, the decision has been made that we have to stop the medicines. The common thing is, like, let's say if you're on escitalopram and you're taking 30 milligrams, the most common thing I see is 5 milligram reduction every week. So 30 milligrams, then you go to 25 milligrams, then you go to 20 milligrams, then 15. So not a very good idea. Actually, it is going to result in significant amount of withdrawals. So what happens is that the medicines, when you reduce them for the 80% reduction, you don't see much of a problem. So it's typically coming slowly, and then suddenly when you reach to the last bit, it is a big dip in it that comes at that time. So consider each dose as individual. So for the first initial reduction, for example, escitalopram is 30 milligrams. You want to come up to 10 milligrams. You can do that fast, but from 10 to 0, consider that to be a problem. Just do it relatively much slower. In some cases, particularly, for example, venlafaxine or paroxetine, that if you're doing it, just make sure that you can consider the option of giving them liquid form, in which you can just reduce the dose by 1 milligram even. But only, once again, consider that it needs to be based on the different medicine. Prozac, for example, has a longer half-life. You don't have to worry about that. Non-pharmacological things, as I mentioned, digital web-based. Exercise has a significant benefit. And the typical question that I get from the patient is that, okay, doctor, get me better and I will do the exercise. My answer is no, you do the exercise and you get better. So exercise 30 minutes, 5 days a week is the optimal exercise that you can use to improve the depression. Okay. What if the patient is not better? There are doctors-related factor and there are patients-related factor. Either patient is not taking the medicine, or patient is not telling you the truth, or the doctor has made the wrong diagnosis, very common thing, or the doctor has not selected the proper treatment. So what to do whenever your patient is not getting better? Optimize, switch, or sorry, it was not argument. It's augment, and then just basically do the augment with the treatment. Okay. Yeah. Well, I think at that stage it's almost like an argument then. Okay, and the evidence base is that now the new trend that we're seeing is ABC, aripiprazole, brexpiprazole, cariprazine as a potential augmenting agent, followed by bupropion, quetiapine, olanzapine, lithium, risperidone, and then all the other potential options that you can consider. So I will just go to the last slide, which is a summary. Make sure that the new treatment approaches are bringing new hopes. And of course, this is not the end. There are a lot of other medicines that you can talk about. Collaborative approach is the best policy. And always use the evidence-based approach. Just only one last thing I will briefly say, and then I will end the discussion. So my grandmother passed away about 4 or 5 years ago, and we had multiple doctors in our family, and she had hypertension and diabetes. When she passed away, when we were just cleaning her room, we found hundreds of tablets under her bed, and we were always under the impression that we were taking good care of her, and we were always giving her the medicines. So remember that if your patient is not getting better, then I can tell you that either they are not taking the medicines, there is a secondary gain, or you have made the wrong diagnosis. So just keep that in mind, and thank you.
Thank you so much.